So surgical revascularization of the lower extremity using bypass grafts to distal targets is an established and effective therapy for advanced ischemia. Recent multi-center data confirms the primacy of autogenous vein bypass grafting, yet there remains a heterogeneity in the utilization, techniques, and outcomes associated with these procedures in current practice. Now, we are sharing our experience with surgical revascularization in very advanced grades of limb ischemia in the patients that have been operated in the last few years. Now, what is PAD? PAD stands for peripheral arterial disease, and you can see that PAD is secondary to atherosclerotic disease and is currently the leading cause of mortality and morbidity in the Indian patients. You can see the peripheral arterial disease just ruins the arteries. Now, here are some quick facts about peripheral arterial disease. It is commonly used to refer to peripheral arterial disease, meaning narrowing or occlusion by atherosclerotic plaques of arteries outside of the heart and brain. The risk factors include high blood cholesterol, diabetes, smoking, hypertension, inactivity, and obesity. The most common symptom is intermittent claudication, which is manifested by pain in the calf region that occurs while walking and dissipates at rest. Now, peripheral arterial disease becomes prevalent with advancing age, and it is greater than 20% cases are seen when the patients are over 80 years. A patient with PAD live in pain and often avoid ambulating, leading to further decline in their functional capacity. So the treatment focuses on reducing the general cardiovascular risks, minimizing symptoms, and improving functional outcomes. We have a combination of medical therapy, supervised exercise therapy, and then the revascularization procedures, which I'm going to talk about in this presentation today. Now, the other term is CLI. CLI stands for chronic limb ischemia, and CLI is the most severe stage of peripheral arterial disease. It puts the patients at severe risk of cardiovascular events, amputation, and death. And CLI is found in more than 12% of the adult Indian population, with increasing incidence, given the lifestyle which we have. The clinical presentation of CLI varies from no symptoms to intermittent claudication, atypical chest pain, rest pain, ischemic ulcers, or gangrene. Now, how do we assess these CLI and PAD? The ankle brachial index is a test which is used for diagnosis, and it is a very simple test that can be conducted in office to confirm the presence of disease. An ABI basically means you put the numerator as an ankle pressure and the denominator as a brachial pressure, and then you divide, then you get this reading of ankle brachial index. So an ankle brachial index of less than 0.9 is abnormal, and it indicates CLI. Now, further going, if you have an ABI between 0.7 to 0.9, it indicates mild disease. ABI of 0.3 to 0.069 is moderate disease, and ABI of less than 0.3 indicates severe disease. Now, before we go on to the actual disease pathology and its presentations and the treatment, let's talk about a little bit about these classifications. These are standardized classifications which are given for chronic limb ischemia, and this classification is basically based on the clinical symptoms and also on some diagnostic tests like the ABI. Grade 0 is asymptomatic, grade 1 is moderate, grade 1 is mild claudication, grade 2 is moderate claudication, grade 3 is severe claudication, grade 4 is ischemic rest pain, grade 5 goes further ahead and goes on to minor tissue loss, which may include a non-healing ulcer, focal gangrene with diffuse pedal edema, and grade 6 is a major tissue loss extending above the dorsal-metatarsal joint level, functional foot, which is no longer salvageable in this condition. Now, this is the classification system which is used to document the patient when they are coming for treatment, also before and also for before and after treatment. And this is the language in which we talk when we talk about CLI. Now this is the clinical classification, and then since this disease affects the blood vessels, so CT angiography is a very important investigation which is used for both diagnosis and the planning of management. And this is a Graziani's morphologic categorization of the disease, in which the disease has been divided depending upon the mild disease to the severe disease. Class 1 is a one vessel tibial disease, and then class 2A, 2B, 3, 4. In class 4, 2 arteries are occluded. In class 5, there is occlusion of all tibial and peroneal arteries. In class 6, 3 arteries or all 3 arteries are occluded. So this is a CT angiographic classification of the disease. Then we have a transatlantic society disease classification, which also divides these lesions into type A, B, C, and D. Now this classification is important for planning treatment and which type of treatment is required for a particular patient. Type A lesions, which you can see, they just have a single stenosis less than 10 centimeters, and then it goes into severity into type B, type C, where you have multiple stenosis, and in type D lesions, you have chronic total occlusions of these arteries. Now there are certain important things which we need to consider. Basically, when we come on to this revascularization procedures, we have the option of either an endovascular stenting or the option of a surgical bypass. So what are the indications of these, and which of this option should be taken for a particular patient? And in this BASIL trial is a very important thing, and this is a very pertinent and important therapeutic decision and a question and also a challenge in the management of chronic limb ischemia. So this bypass versus angioplasty for severe ischemia of the limb trial is the only randomized trial to report on the outcomes. Now it says that surgical bypass for these patients, for those patients who can survive to 2 years or more from the day of presentation, is indicated, and it is and these patients comprise 70% of the study population. Now those with elevated medical risks, inadequate veins, no or minor tissue loss, or with surgical contraindications are the candidates for primary endovascular option. So this guides on the major decision making when it comes to performing surgical vascularization or surgical revascularization for these patients. Now, what are the indications of surgical bypass? One is when we have signs or symptoms of chronic limb ischemia. Second is when there is a Rutherford ischemia grade 4 to 6, which has been defined in the previous slides. Third is a Graziani grade 4 or above disease as far as the CT angiography is concerned. Fourth, when we have frank tissue loss or gangrene. So these are the star indications of surgical bypass. Now, when we come to surgical bypass, we have several options how to perform the bypass. So the bypass can be performed either by a synthetic graft, which is polytetrafluoroethylene PTFE, or it can be performed by an autogenous saphenous vein graft. So which one should be chosen? So the autogenous vein graft has the best long-term patency at all time intervals, whether you see few hours after grafting, whether you see few months after grafting, or even after 2 years, the primary patency of venous bypasses is 81% as compared to 67% for PTFE bypasses. So by far, the graft of choice is the autogenous saphenous vein graft. And obviously it has got a lower cost as compared to these synthetic grafts. But then the PTFE grafts are also indicated in certain situations when the autologous vein is not available or the vein is inadequate, or if the patients have got comorbid conditions requiring expeditious operation, which can avoid the time and trauma of vein harvesting. So those are the few indications when we go for the PTFE grafts. Now coming on to the saphenous grafts or the vein grafts, should we prefer the saphenous graft or there are other options available? By far, the great saphenous vein is the vein of choice, and the reason is that it is easy to harvest. It is of good length and diameter. When great saphenous vein is not available, the arm veins, the basilic vein, can be taken for the graft, and this is required in those circumstances in which the patient has got a previous bypass, stripping of the great saphenous vein, or if there is a poor quality or inadequate diameter of the great saphenous vein. So the arm vein and small saphenous vein are the only alternative autologous vein grafts. Now coming on to the whether these vein grafts, basically since the veins have got valves, so we have to reverse the grafts. So there are two techniques. One is whether to reverse the grafts or whether to use the in situ vein as a saphenous vein. So basically it can be either a reverse graft or a non-reverse or an in situ saphenous vein graft. So the reverse saphenous vein graft has got the best results as opposed to a non-reverse saphenous vein graft where we have to do a valvotomy, but it has got lower patency rates. And the last surgical consideration is the type of anastomosis when we are performing these grafts, whether it should be an end-to-side anastomosis or an end-to-end vascular anastomosis. So a end-to-side anastomosis is preferred for bypass grafting. The end-to-side anastomosis is more demanding surgically. An end-to-side should be preferred. The reason is it maintains the continuity of the native arterial system of the limb for performing endovascular procedures. That is the reason of performing end-to-side anastomosis. Now, a little bit about the surgical technique before I go on to show on the cases. Basically, the teamwork is the essence. You have the anesthesia team, which is busy in anesthetizing the patient and looking after the things during anesthesia. You have the surgical team, you have the surgeon, you have the assistant. All of them have got a separate defined task. You have got the scrub nurses, you have got floor nurses, you've got instrument technician. So basically everyone is assigned a specific role. The surgery is complicated and you don't want to waste time assigning roles in between surgery. And before surgery I usually do an all-team huddle and just try to explain the roles of every person before I perform such surgery so that there is no confusion and they don't waste my time in asking what to do. Now, what are the key steps in surgical bypass? Preoperative assessment of the great saphenous vein is very important by ultrasound. The patient lies in a supine position. The harvesting of the great saphenous vein graft is a very important step. And then once the vein graft is harvested, the graft is reversed. The exposure of the popliteal artery and distal artery, which is the anterior tibial artery or the posterior tibial artery, is also another step. I'll try to show short videos of these steps. And then the proximal end-to-side anastomosis, and then the distal end-to-side anastomosis. So these are the basic steps in performing the surgical bypass. These are very major steps. This is a complicated surgery, and there are a lot of minor steps which are very, very important and which are outside the ambit of this presentation and which I cannot discuss here at this time. So there are many other small but very important surgical steps in performing this surgery. Now, what are the principles of surgical management? Now, these are the key steps in the surgical bypass. And this is supposing we are using the popliteal artery. So this is how the first thing is the advential stripping of the popliteal artery. So this is carried out under microvascular loop. And this video shows how the artery is exposed, the patient is turned to one side, and then the adventitia is stripped while planning for an arteriotomy. Now, once the adventitia is stripped, we do a arteriotomy of the popliteal artery. So arteriotomy has to be very precise, and we don't want to make a small hole and we don't want to make a large hole, otherwise it will be difficult because the access is not very easy, and so therefore the arteriotomy is a very important step in performing the end-to-side anastomosis. Now, once the arteriotomy has been done, you can see how the arteriotomy is being performed in the artery, and we have to be very sure according to the size of the saphenous vein graft how long should be the arteriotomy. Now, once the arteriotomy has been performed, the end-to-side anastomosis is carried out. You can see that this is on the lower part is the segment of the saphenous vein, and this is being anastomosed to the popliteal artery site by microvascular techniques. So this is the end-to-side anastomosis of the popliteal artery with the great saphenous vein. Now, this anastomosis has to be done on all the sides. You first do one side and then you gradually go on to the other side and then you complete the anastomosis. So this is the most critical step, and this is the first step in performing the surgical bypass, the proximal anastomosis has to be done first before the distal anastomosis. So the proximal end-to-side anastomosis is the key step in performing the end-to-end bypass. It should be meticulous. The popliteal artery is deep, hence access may be difficult, and you have to fix the microscope and everything. You have to retract, the muscles are very tight there, and the window may be small in performing this end-to-side anastomosis. So you have to be really sure of how you make your movements and perform the anastomosis. And the most difficult thing is that the saphenous vein is very, very prone to thrombosis. If you don't handle the saphenous vein well, if you don't thrombolize it, it's prone to thrombosis very fast. And the last thing, you have to be, the microvascular technique needs to be precise to deliver the results. Now I'm going to show some of my results of the surgical bypass. I cannot show all the results, but I will show few results which you can have an idea on how the patient presented and what is the profile of the patients which are coming, how we assess the patient, and how we plan the treatment, and what are the preoperative and what are the postoperative results of this surgical bypass that has been carried out. Now this is a patient who presented with gangrene. This is a dry gangrene of the great toe, and also it is involving the second toe. The third toe is also partially involved. The fourth toe is normal, and the fifth toe also has a complete dry gangrene. So, so this patient is a 47-year-old female who came for treatment of this condition. The patient was non-diabetic, non-hypertensive, and she had a peripheral arterial disease with progressive gangrene of the toes of both the foot, not just the right foot, but also the left foot. And this gangrene has been progressively increasing. It started with the great toe, and then it involved more portion of the great toe, and then it involved the other toes. So therefore, this is a progressive atherosclerotic disease, and we have to do something to stop the progress of this gangrene. She also had a severe wrist pain. She was in real pain when she was in the ward, and she had an ankle brachial index of 0.7. She had difficulty in walking because of the pain and because of this tissue loss. And on clinical examination, the peripheral pulses, when we saw the posterior tibial artery was feeble and the anterior tibial artery was not palpable at all. So this patient underwent a CT angiography, and the slide shows the clinical picture on one side and the CT image in the middle. And basically the CT angiography is an important investigation to document these cases. And the CT angiography revealed a diffuse atherosclerotic infrainguinal disease. There is also a lot of calcification in these patients, and there was a long segment obstruction at the level of femoral artery, popliteal artery, anterior tibial artery, and posterior tibial artery. So according to the classification, this disease falls into a type 4 Graziani disease. No vessels were seen in the leg area, just below the knee, but the vessels were seen just above the ankle. The anterior tibial artery was neither visible nor it was palpable. So what do we do in these patients, and what is the treatment planning? So basically, clinically, it's a grade 6 Rutherford disease and type C transatlantic classification disease, and a type 4 Graziani disease as per the CT angio classification, with diffuse atherosclerotic peripheral arterial disease involvement above and below the knee level. So therefore, this patient is not a candidate for endovascular stenting. She's got good many years in front of her. So therefore, she's a strong candidate for surgical bypass. So what I've planned is a proximal uninvolved surgical bypass from the uninvolved portion of the posterior tibial artery, of the popliteal artery to the posterior tibial artery, because the anterior tibial artery is not visible or it is palpable. So therefore, you have to select a good proximal and a distal vessel. Otherwise, if you select in a vessel which has no flow, your anastomosis will not work. So a popliteal artery to posterior tibial artery bypass seemed appropriate for this limb of this patient. And this was a surgical technique. You can see the slides. The amputation of the toe was done, and then simultaneously the surgical revascularization was done. This is the marking for the great saphenous vein. The great saphenous vein is being harvested here. You can see here. And these are the steps in the harvesting of the long saphenous graft for this patient. Now this is the dissection and the mobilization of the popliteal artery using the lateral approach. And once the anastomosis was done between the saphenous vein and the popliteal artery, this is the immediate status on the table following end to side PA to GSV anastomosis. You can see good pulsations both in the posterior tibia, both in the popliteal artery and also in the long saphenous vein. So this was the proximal anastomosis. And then the posterior tibial artery was exposed because you remember the anterior tibial artery was not palpable. So this is the posterior tibial artery which I have shown here. This is the posterior tibial artery and the saphenous vein graft has been anastomosed end to side with the posterior tibial artery. You can see the graft is well engorged, adequately engorged with blood from the proximal anastomosis. So this is the complete anastomosis, proximal and distal for this patient. And this is the immediate post-operative result, the skin condition, and this is the pre-operative and the post-operative pictures. The wounds have been healing. Immediately after surgery, the patient says there is no rest pain. She is relieved of the rest pain. There is a profound symptomatic improvement after surgical revascularization. And then there is a good flow in the saphenous vein graft, which I have done, as well as a good flow in the distal vessel. And this is the post-operative Doppler. Can I have some sound, please? You can hear those sounds. And that is the flow in the saphenous vein graft immediately after surgery. Now we come on to the second patient. This patient had a category 6 Rutherford disease, and the patient's name is Kapoor Chand, 50 years male. Now this patient was diabetic. Now this peripheral arterial disease occurs both in diabetics and also in non-diabetics. So we have got two categories of these patients, and the patient was non-hypertensive. He had a peripheral arterial disease with progressive skin changes, blisters, and ulceration of the left foot. He had severe rest pain with ankle brachial index of 0.6, and he had difficulty in walking. Now, when we examined the pulses,
could you try again?
The popliteal artery was palpable, but the anterior tibial artery and the posterior tibial artery were not palpable for this patient. Sorry about that. Now, the CT angiography revealed a type 4 Graziani disease for this patient. This patient had severe calcifications because calcifications are very common, especially in diabetics, and that makes the surgical revascularization and even endovascular revascularization very difficult. So the infrainguinal vessels had severe calcifications. The posterior artery was visualized, but the right anterior tibial artery was not visualized in the distal aspect. The left anterior tibial artery was attenuated in the distal aspect. So the treatment planning for this patient with a grade 4 Rutherford disease and a progressive pathology and a diffuse atherosclerotic peripheral arterial disease, endovascular stenting was not preferred because of the calcifications and because of the vessel status, and therefore this is a candidate for surgical bypass. So I performed a proximal uninvolved popliteal artery to an anterior tibial artery bypass for this patient to augment the blood flow in the ischemic limb. So this is the patient at the time of surgery in which the debridement of the wound was done, and after debridement, the soft tissue cover of the wound was done, and at the same time the soft tissue was done, the limb was revascularized surgically, so that he's got a soft tissue cover and he's got a new blood supply to his foot. So in this patient, the saphenous vein was not of good caliber, and which was assessed by preoperative ultrasound. So as I said, you have to see the saphenous vein because you don't take it for granted that a saphenous vein is going to be there. So if the saphenous vein is not of good caliber, so you have to go for other veins. So in this patient, I took the basilic vein, and you can join those median veins and the basilic veins, and you can have a long segment vein for this vein bypass graft. Now this is the third patient and the last patient. Now this patient had a category 6 Rutherford disease, you can see the condition of the limb. There are ischemic changes in the leg, and then there is a dry gangrene involving both the foot, and it is more on the left side. So he's Pushpendra, 35-year-old male. He's non-diabetic, non-hypertensive, and a chronic smoker. So that is one of the important predisposing factors. So he had a progressive gangrene of the toes of both foot and the skin changes. And the disease was more on the left side with involvement of all the four toes. And since the disease was progressive, he had a lot of rest pain. So he had come for treatment. And these are the pictures of the limb on the left side and also on the right side showing the clinical disease. And this is the limb. You can see here the involvement of the anterior tibial artery angiosome. Basically, we have got the angiosome concept. And we have to treat according to the angiosome concept. We have got the angiosome of the anterior tibial artery, angiosome of the posterior tibial artery. So therefore, he had a disease of anterior tibial artery angiosome, and therefore the patient needs a revascularization of the anterior tibial artery. He had a partial dry gangrene of the great toe, subtotal gangrene of the second toe, and partial gangrene of the third and fifth toe. He had a grade 4 of the IC classification. He had a lot of rest pain. He had intermittent claudication, and the ankle brachial index was as low as 0.6 on the left side and 0.7 on the right side. I'm sorry about the CT pictures, they got rotated, but on CT angiography, the patient had a greater disease on the left side, which is showing more tissue loss clinically also. The popliteal artery was normal. The posterior tibial artery had reduced caliber, but the anterior tibial artery was not visible on the left side. And the similar changes were also observed on the right side, also with an attenuated anterior tibial artery. So after this clinical and radiological assessment, the planning of this patient was done. So this patient has a grade 4 Rutherford disease and a progressive dry gangrene of the foot, a diffuse atherosclerotic peripheral arterial disease. The patient is a smoker. Endovascular stenting is not preferable, and this is a candidate for surgical bypass. The proximal uninvolved popliteal artery to anterior tibial artery bypass seems the most appropriate for this limb, and that was exactly was done for this patient. You can see here some of the pictures here, how the popliteal artery has been exposed and it has been pulled by these stay sutures. And then this is the great saphenous vein which has been taken out, and this is the end-to-side anastomosis for this patient, showing the saphenous vein which is engorged with blood from the popliteal artery. This is the popliteal artery and this is the saphenous vein, the end-to-side anastomosis. So once you anastomose the saphenous vein with the popliteal artery, you have to have a good flow in the saphenous vein. And I've got this video to show the amount of flow, the quality of blood flow which you can get if you give a good anastomosis with the popliteal artery. So this is the spurting flow which has been obtained in the saphenous vein after the proximal anastomosis. And this is the surgical technique of the distal anastomosis. So we always do assessment of these patients, and this is the Doppler study on the second day. You can see you can hear the pulsations. And this patient came for follow-up, and this is the result after 6 months of follow-up: improvement of the rest pain, improvement of the symptoms, symptomatic improvement, and the patient is mobile and patient has gone back to his regular activities. There is a good healing in the stump because there is good blood supply after debridement and after surgical revascularization procedures. And this was the patient in the OPD. You can see he is able to walk comfortably. There is no pain. This is 6 months follow-up. So there is no rest pain, there is no claudication. The patient is gaining strength in the leg. The patient is getting back to normal activities. And then we got a Doppler study, 6-month follow-up Doppler study from the radiology Pushpendra. So the Doppler study shows a normal flow in the saphenous vein graft, which I've highlighted here after 6 months, and it is also observed clinically. So these were my patients. I would just like to conclude by saying that accurate evaluation is the key to management of this difficult condition. Surgical intervention should be quickest before setting of gangrene, and the surgical technique is demanding and needs high degree of microvascular expertise and is prone to failure if the essential steps are not performed in these patients. The anastomosis is also tricky and often fails, as the great saphenous vein is a very delicate structure and it is very prone to easy thrombosis. Meticulous postoperative monitoring is also essential. You have to see the patient after surgery, and if there is any problem, the patient has to be re-explored and the anastomosis has to be redone. And of course, the technical factors are very important, like what conduit you are choosing, whether it's a great saphenous vein or the other vein, or whether it is a PTFE graft. That is very important. The most important thing is the inflow and the outflow vessel. The inflow vessel has to be uninvolved. It has to have a good flow. And also very important is the outflow vessel. The outflow vessel, the principle is you have to take the best flow which is available most proximally. So that is the vessel. And an adequate caliber, good quality, great saphenous vein is the optimal graft for distal bypass in the leg. And this is what the literature says, and this is what is our experience. Alternate veins perform acceptably in presence of great saphenous vein, whereas prosthetic and other conduits have inferior outcomes. The outflow vessel should provide unimpeded runoff to the foot, otherwise the anastomosis is going to fail. I'd like to thank the anesthesia department for their great help in performing these procedures and for staying with me in those long hours of surgery. I'd like to thank the radiology department, Dr. Raghunandan, especially for his help. I'd like to thank the endocrinology department, the neurology department, the physiotherapy team, and the entire nursing and OT staff of my department. Thank you very much.